Hello, everybody. I welcome everybody to the ESID Clinical Working Party webinar. I will host today's webinar, and I'm very proud of many speakers agreeing to speak on the topic of CTLA4 and LRBA deficiency. We will start with Elena, a PhD student of mine, who will remind us of how to diagnose CTLA4 and LRBA patients. Then we're very grateful to Gulbu Uzel from the NIH, who is the first discoverer of the CTLA4 insufficiency, haploinsufficiency. And thank you, Gulbu, for agreeing to speak about your management experience with CTLA4. And thank you, Safa Baris from Turkey, for speaking on your valuable experience on treating patients with LRBA deficiency. This will be then followed by Máté Krausz, another PhD student of Freiburg, who is the lead person in the ABACHI trial, a trial where we use abatacept for the treatment of CTLA4 and LRBA insufficient individuals in a controlled way. And we are looking forward to his case reports of 20 patients who have been treated. And then finally, we're looking forward to the discussion with Claudia Wehr and Carsten Speckmann, both again from the CCI in Freiburg, on the topic of bone marrow transplantation in these patients. So without further ado, I would like to ask Elena to start with her presentation.
One second. Good afternoon from my side. Thank you for the kind introduction. Today I will tell you how to evaluate variants of unknown significance in CTLA4 and LRBA. LRBA deficiency and CTLA4 insufficiency are both inborn errors of immunity that clinically overlap. They're characterized by autoimmune manifestations and recurrent infections that are often severe and life-threatening. And in addition, patients often show a poor humoral immune response with hypogammaglobulinemia. While LRBA deficiency is an autosomal recessive disease and caused by biallelic mutations in LRBA that abolish or completely reduce protein expression, CTLA4 insufficiency has an autosomal dominant inheritance pattern and is caused by heterozygous mutations in CTLA4. Not every individual, though, that carries a CTLA4 variant is affected. Some don't show any symptoms, which results in an incomplete disease penetrance of around 70%. And due to this incomplete disease penetrance, CTLA4 insufficiency can be inherited across generations. CTLA4 is mainly expressed in regulatory T cells and activated T cells. It's located in the intracellular compartment, and after TCR stimulation, it is rapidly upregulated at the cell surface. Its main function is the inhibition of T cell activation and thus the inhibition of the immune response. One mechanism how it does so is by binding to CD80 and CD86 with a higher affinity and avidity than the co-stimulatory molecule CD28. It can not only bind to its ligands, it can also rip them out from the antigen-presenting cell and engulf them by a process called transendocytosis. After CTLA4 engulfs its ligand CD80 and CD86, it has two fates. It is either lysosomal degraded in case AP1 binds to it, or it's recycled back to the cell surface and undergoes another round of cell inhibition, which is facilitated by LRBA. In the absence of LRBA, however, there's less recycling and an increased CTLA4 degradation, which leads to reduced CTLA4 expression on the cell surface, resulting in an uncontrolled and prolonged T cell response that we also see in our patient. Although LRBA deficiency is detected in minority in our cohort, it is detected with high frequency in other countries, for example, Turkey and Africa. However, in our cohort, CTLA4 insufficiency is one of the most frequent monogenic causes of CVID. It is diagnosed by the clinical presentation of the patient and additional genetic sequencing. However, after genetic sequencing, one still needs to clarify if the identified variant has biological and functional consequences. And there are some functional tests that are frequently run, but they have some limitation. One is to measure the CTLA4 expression extra and or intracellular. However, here only the expression of the protein is analyzed and not its function. And we sometimes have CTLA4 variants that still have a normal expression, but still the function could be impaired. The second assay is a Treg suppression assay. However, this assay is quite biased since CTLA4 insufficient patients often have altered Treg numbers. What we do in our group to evaluate CTLA4 functionality is to perform a transendocytosis assay, which allows us to measure how much CD80 was taken up by the CD4 T cells of the patients. And I will quickly explain this in more detail. So we always receive blood or PBMCs, and then we perform two parallel assays. One focuses on the CTLA4 expression, for which we stimulate PBMCs with anti-CD3 and CD28 for 16 hours. And then we stain them for CD4, CD45RO, CTLA4, and FOXP3. And here we have two different staining approaches that allow us to distinguish between the surface and the intracellular CTLA4 expression. To measure the function of CTLA4, however, we isolate CD4 T cells and co-culture them with Chinese hamster ovary cells that stably express CD80 that is coupled to M scarlet. Therefore, they function as an artificial antigen-presenting cell. We also stimulate the cells and add baphyllomycin, which prevents the lysosomal degradation of the internalized M scarlet CD80 by the CD4 T cell. On the next day, we also stain the cells and then analyze the percentage of transendocytosis using flow cytometry. This assay was first established in 2015 by the group of David Sampson. They used CHO cells that express CD80 coupled to GFP. We then switched to the fluorophore M scarlet, but as you can nicely see, using both cell lines, you have a highly specific and sensitive assay. The reason why we switched to M scarlet is that M scarlet is more stable than GFP. GFP is easily quenched in an acidic environment. And using these M scarlet cells, you have a higher percentage of transendocytosis and just a better visualization, which helps us to distinguish between the healthy donors and the CTLA4 deficient patients. Using our M scarlet CD80 CHO cells, we have now analyzed 19 different patients with 18 different CTLA4 variants, of which 2 are splice site variants, 3 are frameshift, and 15 are missense. And overall, the CTLA4 variants reduce the transendocytosis percentage in comparison to wild-type CTLA4. And when we then directly compared each patient to their healthy control, you can see that the frameshift and the splice site mutations lead to a highly reduced transendocytosis, but we also have some mutations, and they're normally missense mutations that show normal transendocytosis. And this underlines how essential this testing is, because not always the CTLA4 function is impaired. This test can also be used to measure how active or how functional CTLA4 is in LRBA deficient patients, since LRBA recycles CTLA4 back to the cell surface. There's often a reduced CTLA4 expression, and this could have an outcome on the CD80 ligand uptake. We have analyzed 7 patients with variants in LRBA. We also observed an overall reduced transendocytosis percentage in comparison to the healthy controls. However, this is not as prominent as for CTLA4. When we directly compare each patient to the healthy control, we have 5 patients that showed reduced transendocytosis and 2 patients that showed normal transendocytosis. In addition to the transendocytosis test, we have a second diagnostic test established in our group, which is specifically to measure the LRBA protein expression in patients with suspicion of LRBA deficiency. This rapid flow cytometry assay was published in 2018 by Laura Gamis-Diaz from our group, and in comparison to genetic analysis, which is quite expensive and time-consuming, and Western blot analysis, which is a bit tricky since LRBA is quite a large protein, this accurate and cost-effective FACS assay is quite straightforward. Here we also use PBMCs and use some of these PBMCs to do a FACS analysis for CD69 and LRBA on day 0. And the other part of the PBMCs we stimulate with PHA or leave unstimulated for 3 days, and then again check the CD69 and the LRBA expression. And here's one example of a healthy donor and a patient. In light gray, you can see the unstimulated condition, and after PHA stimulation, you can see an increased LRBA expression. While this is not the case for the patient, here the LRBA expression is reduced. And parallel to the LRBA expression, we also always check CD69 expression because we would also want to know if the stimulation has actually worked. And here you can see that both the healthy donor and the patient have a similar CD69 expression, and corresponding to the histogram, the patient has a reduced LRBA expression. To validate if a patient is definite LRBA deficient or non-LRBA deficient, we calculate the MFI ratio by dividing the stimulated mean fluorescence intensity through the unstimulated intensity. And if the MFI ratio is below the cutoff value of 2.6, it means that the patient is definite LRBA deficient, while above it's non-LRBA deficient. We've now so far analyzed 78 individuals with suspicion of LRBA deficiency, of which 38 were definite LRBA deficient and 40 were non-LRBA deficient. And to summarize this, for the assessment of especially CTLA4 gene variants with unknown significance, we have a highly specific and sensitive assay, the transendocytosis assay, where we can measure the CD8 ligand uptake by regulatory T cells and also the CTLA4 expression. We've so far analyzed, using these M-Scarlet CHO CD80 CHO cells, 19 patients with 18 different CTLA4 variants, of which 13 showed reduced transendocytosis and 5 showed normal transendocytosis. And this indicates how essential this functional testing is, because only having a variant in CTLA4 does not mean that the function is impaired. This assay can also be used to identify the CTLA4 function in LRBA deficient patients. In addition to this, we have a flow cytometry-based assay that allows the fast screening of LRBA expression in patients with suspicion of LRBA deficiency. And if you're interested in evaluating patients with CTLA4 or LRBA variants, you're always welcome to contact us. We are still running these tests in our lab and are frequently receiving samples. The LRBA protocol is also published, and in the future, we would like to share the CD80 and Scarlet cells with you. And with this, I would like to thank Bodo Grimbacher and Laura Gamis-Diaz, who are the heads of the CTLA4 and LRBA research, and also my supervisors, as well as the whole AG Grimbacher, especially my former colleague Jessica Rojas, who performed most of the functional tests before I took over, everyone else involved in this project, and of course the patients and their families, and you for your attention.
Thank you, Elena. Thank you, Elena. We will have questions and answer session after the talks. So I would like to next ask Gulbu to present her data on the management of CTLA4.
Right. Let me share my screen. Right. Thank you very much for having me join ESID for this grand rounds. And this is the first time I'm doing this with ESID, and I'm very happy to see names of some friends and some familiar faces. So I don't know if Cliff Notes is a concept in over Europe, but it's like our little in high school or middle school, it's our little cheat books going through big novels or big workbooks, and it kind of helps us helps our kids to get good grades and do well. So I'll try to share some of my Cliff Notes. That's not very formal, but we'll give some clinical vignettes, and try to share the clinical experience as well as a little bit of science behind it. All right. So we'll start with a semi-complicated patient, and I highlight the word semi. This was a 29-year-old male with a history of communicable immunodeficiency, granulomatous interstitial lung disease, and autoimmune colitis, autoimmune hemolytic anemia, for which he was splenectomized. He has received a match-related donor bone marrow transplant in 2003, not at another center, with reduced intensity conditioning using alemtuzumab, TBI, Cy, ATG, and he ended up with resultant mixed chimerism, but clinically initially improved PFTs. Within a year, his engraftment declined to 41% in T cells, and then further more drop gradually, and then he returned to his prior disease manifestations. He was diagnosed with granulomatous hepatitis and periportal and sinusoidal fibrosis at that point. Other autoimmune problems that surfaced prior to his referral to our center was hypothyroidism, psoriasis, duodenitis, gastritis, and proctitis, and he had a lot of lymphocytic colitis. As you can see, the CTs are trying to demonstrate the lung disease as well as mediastinal lymphadenopathy. And the PET scan here is showing hot PET avid areas in the extranodal sites. So in July 2021, he was diagnosed with EBV negative extranodal marginal zone lymphoma based on this biopsy following this PET CT. And he had not just extranodal multiple sites, but also subcutaneous tissue infiltration too. So he was, for his marginal zone lymphoma, he was treated with rituximab 4 times, along with ibrutinib with excellent response. He was in complete remission and was evaluated for a retransplant. In the meantime, all this was going on. He was also enrolled in a whole genome sequencing, this is what we got from whole genome. It was like a heterozygous missense variant in CTLA4. It's a known variant that we have had a couple other patients with this variant. In his flow cytometry evaluation of his CTLA4 showed diminished FOXP3 compared to healthy control, diminished CTLA4 compared to healthy control, but in comparison to all other CTLA4 patients, much sicker. This is not a totally bad CTLA4 expression. And with IL-2 stimulation over 2 days, he was able to upregulate his CTLA4 as well as his FOXP3 to the level of healthy control. So knowing that he had a mutation, although his CTLA4 expression wasn't too bad, he his patient was heading towards transplant. We gave him IV abatacept at 4 doses altogether within a short period of time while awaiting his transplant. Here, the aim was to reduce the organ-specific lymphocyte infiltration and autoimmunity prepping for transplant. He had an matched with DQ mismatched donor transplant earlier mid last year, using a regimen including ATG, pentacillin, and cyclophosphamide. So he engrafted. There were some hiccups after the transplant, but he did pretty well. So the question that I am expecting you to ask me, what was going on with the donor? So his initial donor was patient's brother, who shared the same CTLA4 variant. So it's a sad story, but probably this is why his CTLA4 expression is not too bad. And then you look at brother's CTLA4 expression, who is totally asymptomatic, is similar to the patient. So this is I guess this was the common team trying to transplant patients before before the time that we were able to pinpoint CTLA4 defect. Moving on from here, I just gave this example to highlight the fact that we rushed in several doses of abatacept prior to transplant, just to keep things a little bit under control, cool his autoimmunity, activated T cells, and let him have a smooth sail until the transplant. So this is one thing that I always tell everyone to think when you are getting ready to treat a patient with CTLA4 defect or LRBA defect. What is your treatment target? What are you trying to treat? Are you trying to handle lymphoproliferation, or are you primarily dealing with cytopenias, or is your patient's your primary focus is to control the inflammatory lesions in the brain, or are you worried about the lung disease, the interstitial lung disease, lymphocytic infiltrates, or is it just the GI symptom that your patient is presented with, and that's what you're handling? And are you thinking about what's going on in terms of viral infections? As we have experienced most of the time, these patients can have intermittent CMV, EBV viremia, JC virus viremia, and as we recently had a patient who had active Kaposi, an HIV negative CTLA4 patient. So trying to manage the autoinflammatory lymphoproliferative symptoms in the setting of those active viremias becomes a bit of a challenge. And then what is your optimal goal in terms of your patient's outcome? Are you trying to prevent malignant lymphoproliferation? Are you targeting that? Are you keeping that in mind? Because the incidence of lymphoma in our cohort is around 23 to 25% in these patients. Other thing that is really critical and that you need to consider looking, if possible, remind yourself what are you targeting, what cells you're targeting is looking at the pathology, because as in the brain biopsies, there are a lot of plasma cells besides T cells and B cells. But once these patients see a lot of steroids, which is used in the setting of these infiltrates to close the blood-brain barrier, along with other immunomodulatory drugs, you can easily be simply be left by some plasma cells. And rituximab, when used in the setting, can push these plasma cells with deviated kappa-1 expression and may induce a little bit of worrisome clonality in subsequent biopsies, which we have experienced. So keeping in mind what you're dealing with, what is in the biopsies, and how you may handle the problem, I think is a critical thing. So I am going to go the other way around. Instead of talking about abatacept first and our experience, I will briefly go over our experience with repologs or mTOR inhibitors. And as you know, these are these targets of rapamycin or everolimus are mTOR and mTOR1, and indirectly in the long run, some mTOR2. So how does that work in terms of CTLA4 deficiency? Yes, they inhibit the PI3K/mTOR pathway. But the biological relevance of using these drugs is that they interfere with CD20 signaling, which is the counter-regulatory signal for CTLA4. They control overt proliferation and expansion of T cells. They reduce T cell exhaustion. All these have been proven in mouse models and humans. They are able to support Treg expansion and activation, induce T cell energy, and induce autophagy. So all the good things that you want to have in your pocket if you have a patient with CTLA4 and all those problems. So what we have done, and some of these patients, we have started treating them with rapamycin even prior to figuring out that their defect was CTLA4 more than a decade ago. Was that we looked at if they had lymphoproliferation, we wanted to reduce lymphadenopathy. If they had significant splenomegaly, we targeted that. And if they had significant constitutional symptoms due to ongoing lymphoproliferation, that was a clinical outcome we wanted to follow. So the medication and dosage were as follows. For sirolimus, we use around almost 3 to 3.4 milligram per meter square. Everolimus, we use 1 milligram per meter square. For sirolimus, we did loading dose, and it varied between pediatric and adult patients, but always targeted a serum trough level of 9 to 15 for sirolimus, and everolimus 5 to 7. Everolimus has a little bit shorter half-life. It's BID dosing, and some patients who cannot tolerate sirolimus due to oral ulcers or some skin rash or headache, which are the common problems. Luckily, we don't see too often. Those patients can do better on everolimus. So here's our thing. What we did that when we treated our initial patients with sirolimus, we took their blood and PBMCs, cultured them with IL-2 with and without sirolimus, oral dosing, in vivo oral dosing, and patient cells that had seen sirolimus or mTOR inhibitor in vivo, those cells did much better ex vivo, had better Treg profile with increased FOXP3 expression, more CTLA4 expression, and they responded to IL-2 beautifully. So this was our ex vivo proof of sirolimus is a good thing for Tregs in this disease. We also did with Eric's help and his lab worked very hard on multiple patient samples that had been treated with mTOR inhibitors, looking at ex vivo Treg suppression. This is a very laborious assay, as you can see, and patients' Tregs that are sorted, which 2 steps are co-incubated with effector T cells, patients, or healthy control, and looking at Tregs able to just suppress proliferation. So what you're seeing here is that cells, both Tregs and effector T cells, are both from the patient or healthy donor. And what we have seen was that patient with just type 1 diabetes with CTLA4 or diabetes plus minus thyroid disease or limited autoimmunity didn't have any defect in ex vivo Treg suppression. Only those that had multi-system disease had diminished Treg suppression. And those patients that were on mTOR inhibitors did very well. They corrected their suppressor defect. We had only one patient who had was on abatacept that during this sampling, so cannot make a deduction. But then we were able to, it was able to mix and match, compare effector cells of the donor and suppressor cells of the patient. And what we concluded that the defect there is in regulatory T cells rather than effector cells, and with patients, regulatory T cells did not suppress healthy donor effectors, whereas healthy donor Tregs were able to suppress patient cells. But the key point here is that with patients that were treated with mTOR inhibitors had normalized their suppression assay, which points out the sirolimus effect on or mTOR effect on the regulatory T cells. And then the what is expected, what is the well-known much loved rescue abatacept is used by now all of you, everyone, in the treatment of disease. But I brought this up and just to highlight the fact that there are many different ways that abatacept is bringing an immune homeostasis in your patients. It's not just competing of CD28 for 80 or 86, but it's also interfering with dendritic cell Treg synapse, but also suppressing B cell autoantibody production. And level of rheumatoid factor antibody production was one of the outcomes that they originally evaluated in patients with rheumatoid arthritis. But it also has calms down the cytokine production besides CTLA4 and its ligand interaction, improving the effector T cell overextension. So when you patient is treated with abatacept and you look at their effector cells hyperproliferation, that normalizes with CTLA4 treatment. This was about 18 hours after an IV infusion. A quick one last patient example that I would like to share with you, and just to highlight in what settings we might or we should be thinking about using abatacept. It's a little bit unusual example, but hopefully we'll be able to encounter these patients more frequently as we expand family screening. So this was a 70-year-old female patient carrying the known family mutation. One of our original mutations stopped, so true haploinsufficiency. Returned for a routine follow-up. We started seeing her annually. She was healthy. She had a blood glucose level of 126, fasting. Her hemoglobin A1C was 6.1, with normal C-peptide random at 1.9. She was non-ketotic. Her oral glucose tolerance test was totally abnormal. Her autoantibodies to IH2, ZNT8, and GAT65, and anti-ILSA were highly positive. So she was stepping into type 1 diabetes, and she had the HLA risk allele of DQB0303. This is the risk allele for the general population. We were looking for the risk allele that are relevant for checkpoint inhibitors, because their defect is like a checkpoint person receiving checkpoint inhibitor, but she didn't have that HLA. So she was still at risk for type 1 diabetes. She had the CTLA4 mutation. She had family members with type 1 diabetes, and she had elevated A1C with islet cell targeted autoantibodies. So those are the criteria for diagnosing early in the early phase of type 1 diabetes. We were probably at a point where we estimated that she had maybe 30% islet cells left, because she was already experiencing hyperglycemia, and she had all the antibodies. We offered the family to start her on a combination of IV abatacept and rituximab. However, the family didn't choose not to go with rituximab, so we started her on abatacept 10 mg per kg per dose, IV once a month, and quickly escalated to the maximum dose that is known to be used in one infusion in any patient. It's 30 mg per kg per dose and a maximum of 1 gram. 4 months later, we started additional sub-Q abatacept injections in between her IV infusions. It's a very aggressive schedule, but with that, we were able to induce a drop change in her autoantibody levels, which were checked monthly most of the time outside the pandemic, and she maintained her C-peptide at low level. We started her on low dose insulin just not to stress her islet cells. But now, almost over 3 years from the initial onset of our initial diagnosis of her diabetes, she remains on IV abatacept and still has her own C-peptide. So we have saved some islet cells. However, we don't know if we stop the abatacept infusion, she will be able to maintain what she has. Probably not. So, and the last question, this is a question, and for you, it's just a little puzzle of another gentleman who's 42 years old, who was referred to us for his complicated CTLA4 defects, and which the gene had two variants on the same allele. They're both novel. And what we didn't do the transendocytosis assay with not in the mutations, but we did transfected the 293 T cells and looked at which variant is more likely to be the disease causing. And as you can see here, G173R was the one that diminished CTLA4 expression, and we have verified that by fluorescence as well. It's just that we knew what was pathogenic. Not that it made any difference in terms of our decision for treating him. So he was very pancytopenic with hypercellular marrow, with a lot of T cell infiltrates, had lymphocytic colitis with proteinuria and neuropathy, again, horrible nodular regenerative disease of the liver with portal hypertension, his splenomegaly, and prior history of thyroid medullary carcinoma. So this was a patient in no way a good candidate for transplant, given his liver disease and portal hypertension. So we gave him high dose IV abatacept, which is the standard dose per weight, but using it every 2 days until we got a response, and he became quickly transfusion independent. We did combine it with sirolimus in a couple of weeks following the abatacept, as he was doing well, a year later, into this treatment, he became refractory to abatacept. Refractory in the sense that his marrow showed excessive T cell infiltrates and that were non-clonal, and he started dropping his cell counts. He became quickly neutropenic. So at this point, my question, this is, I think, something that I would love everybody to bring up their opinions, is that what would you do? What would you treat him with next? I will say this and I will stop. and just the pictures of everyone that have done a lot of contribution to this work over the years at NIH.
Thank you so much, Gulbu. We will leave questions to the end, and I would like to call next Professor Safa Baris to the podium and deliver his talk, and he has great experience with managing patients with LRBA deficiency. Thank you, Safa, for agreeing to participate.
Yes, thank you, Bodo, and thank you for this webinar. And I will present how we can manage patients with LRBA deficiency. So, we started from the 2018 to recruit a patient with the LRBA deficiency, and as you see here, that there was 22 patients in the beginning, and after collecting those patients from the different centers located in Turkey, now we have 63 LRBA deficiency and 35 CTLA4 haploinsufficiency patients. So basically what we are doing for those patients after collecting the baseline clinical and immunological data, so we follow up prospectively those patients in each centers and looking for clinical features and long-term outcomes, especially for the treatment options, also the efficacy, how they respond to the different kind of the immunosuppression or abatacept, and record also the side effects of therapy and monitoring the changes in lymphocyte subsets. So as a goal in this cohort, looking how we can treat those patients precisely, especially in terms of the immunosuppressant, abatacept, or hematopoietic stem cell transplantation. So here this is our first publication. It's published in the JACI in Practice in 2019. So we investigate the efficacy of abatacept in LRBA deficiency, and there was 22 patients also coming from different centers. As you see, that's mainly those patients are males. The current age, the mean was 13 years. And there was a delayed time in the diagnosis, that the mean was 9 years in this cohort. So we had 18 patients with the receiving abatacept, and the median duration of the abatacept therapy was 1 year. And when we categorize the symptoms of the patients according what they have, as you see here, that's and then we try to look how abatacept affect those manifestations, especially when you look to what's abatacept doing in those patients. That's the lymphoproliferation, chronic diarrhea, respond very well, and then this followed with the immune dysregulatory manifestation. But the immune dysregulatory manifestation is not completely respond to abatacept. As you can see, the most of the patients still suffer from some symptoms during the follow-up. But here, as you see, that's the cytopenias, especially the autoimmune cytopenias, responded very well to abatacept, and almost all the patients showing complete controls. And of those, after the treatment with the abatacept, as you can see here, that's the quality of life in the all tested analyzed patient increased nicely after the treatment. Since also in our cohort, patients coming from different centers, and the preference of the using of drug dose and the intervals abatacept was changeable. So we try to compare each drug intervals to others. As you can see here, the time of symptoms controls was shorter when in patient who are receiving abatacept in 1 week or 2 weeks. starting those with these intervals when you compare to the 4 weeks treatment. And also when we compare 1 week to 2 weeks interval receiving abatacept, that's the 1 week show better rate of remission in terms of the symptoms what the patient had. Also here, by the collaboration with the Professor Talat Çatıyla from Children's Boston Hospitals, we looked for the LRBA deficient patients that they have a high level of the follicular helper T cells, especially this due to the insufficient CTLA4 mediated Treg expression that's lead to the high level of the TFH, and these cells also have a high activated markers like ICOS and PD-1, and those markers also the cells decrease with the nicely with the abatacept therapy. So we also check these cells in our cohort. As you can see, that the majority of the patient, the baseline had a high TFH. By this reduced after treatment with abatacept. Also, the marker of PD-1 was high in the baseline, which decreased nicely after treatment with abatacept. And also, we in this study we looked for the if TFH also can be helpful to predict which patient can be resistant to abatacept therapies. Here we had 2 patients that have a severe phenotype. As you can see, the baseline they have a high level of the TFH, and also they still to have this level of TFH despite they receiving abatacept. And only in 1 patient, these cells decrease after transplantation. And this shows that the TFH was able to show the resistance or to predict the response to the treatment. So to conclude this part of the study, we showed that abatacept was able to control different immunoregulatory manifestation in LRBA deficiency, and more favorable responses achieved when the drug started for the weekly or bi-weekly drug regimens. And we showed that TFH is useful to follow the disease activity, especially, and also showing a patient who can be resistant to therapy, which requires alternative treatment modalities. So what we move now to the expand our cohort, and we have now 63 LRBA deficient patients, and we started to looking for those to understand the course of disease, also what kind of the treatment they are benefits. As you can see here, that's the median current age of those the patients 17 years. We followed them. The median follow-up were 4 years, and most of the patient coming from with CVID phenotype, and also some with ALPS and IPEX. There was 4 patients with CTLA4 haploinsufficiency as an unaffected carrier, while LRBA deficiency presented with full expression. So at the end of the study, we had 8 patients died in the LRBA cohort, while 1 patient in the CTLA4 haploinsufficiency. And when looking for the clinical phenotype of those disorders, they are quite similar, but there is some difference in terms, especially for the respiratory tract infection, which was high in the LRBA deficiency. Also the immunoregulatory manifestation, chronic diarrhea, and also some failure to thrive, also high in the LRBA compared to CTLA4, which also same with the literature that's showing that we know that's the LRBA deficiency having more severe phenotype. And this is the medication which used in our cohort. It's when the majority of patients receiving immunoglobulin replacement therapy, and also prophylaxis, especially for the bacterial strains, also antiviral fungal prophylaxis, Majority of patients received immunosuppressants, also abatacept to control the ID manifestation. CTLA LRBA deficient patients, also we have 14 patients underwent transplantation, and splenectomy in some patients. And this treatment was high in LRBA deficiency compared to CTLA4 haploinsufficiency. So looking for to what kind of immunosuppressant, as you see that there are 41 immunosuppressant in LRBA deficiency, while 20 in CTLA haploinsufficiency, and abatacept were used in 42 patients in LRBA cohort and in 16 patients in CTLA4 haploinsufficiency. And transplantation, as I said, it's only conducted to LRBA deficient patient, and there was 14 patient there. And this is the immunosuppressants. Apart from the abatacept, as you can see, that's the most of the patient used corticosteroid, which followed the mycophenolate mofetil and cyclosporine. The other is coming with rare frequency, and the majority of our patients receiving 2 or 3 immunosuppressants to control their autoimmune or other immune dysregulatory manifestations. And we compare the immunosuppressants to abatacept. As you can see, that's the immunosuppressant showed more partial responses or non-response responded to the therapy to control the disease manifestations. And usually patients required 2 or 3 courses to use of these immunosuppressants to control disease activity. While looking for the abatacept group, majority of patients showed chronic complete response, and some still have a partial response, but this is lower than the other immunosuppressants. So also we compare the partial responded patient to abatacept to complete responded patient. As you see that in the clinical part, those partial responded patients, they had longer disease course and with multiple organ involvement, as they have more colitis, more ILD, and they have in the flow cytometer high CD8 cells, also high CD8 TEMRA cells, and they need more immunosuppressants, especially sirolimus or azathioprine, to control their manifestations. While the complete responded patient, usually after receiving abatacept, they stopped all the immunosuppressants. And this is the Kaplan curve. As you see, that's the complete response patient showed 100% of the survival compared to the partial responded patients. And looking for the indications or for the usage of the abatacept, as you can see that usually the centers use this targeted therapy to control chronic diarrhea, lymphoproliferation, and immune dysregulation. And this was very nice working with the chronic diarrhea and lymphoproliferation. A majority of the patients showed complete response, while immune dysregulation, because it was different in nature, 60% of the patients showed complete remission, especially for the autoimmune hemolytic anemia, ITP, hepatitis, arthritis, showing very nice control, while interstitial lung disorders, demyelinating disease, or alopecia showed less response to abatacept. While in our cohort, type 1 diabetes did not show any benefit to abatacept. And looking for the dose and the interval of the abatacept, and there was 58 patients receiving abatacept with the median use time up to like 2 years, the maximum 6 years in some patients. And usually they received abatacept with the IV route, while some with the sub-Q route. And when we look for the side effects, we didn't see any severe side effects and all the side effects were uncommon, usually mild and transient, like especially localized to skin, like they have a mild eczema, some herpes simplex or zoster infections, and we stopped treatment only in one patient due to EBV PCR positivity. And after the therapy, the immunoglobulin therapy or other prophylaxis did not change after abatacept therapy. And in some patients, we stopped abatacept. That was in 18 patients, the majority of them due to transplantation, while in 2 patients due to result indication, in 1 patient due to EBV activity, and in 1 patient due to inadequate response. And we skip some doses due to the activation, PPD activation for the TB in 2 patients, and also infection after the initial dose in 1 patient. So looking for the transplantation, 14 LRBA patients transplanted, as I said. The majority of them, they're still alive. And the median transplantation, the age was 20 years. It was late a bit. And those usually the patients having a severe phenotype with multiple organ involvement. And this is the post-transplant follow-up with the median almost 3 years. Majority of them received match HLA donors with conditioning, and some of them suffered from GVHD and CMV reactivation. And also there were 4 patients after transplantation still requirement to the immunosuppressants due to intractable ITP or diarrhea. And at the end of the study, there were 3 patients with the non-donor chimerism. 2 of them died due to GVHD, multi-organ failure, and VOD and sepsis in 1 patient. And this is the final outcome of the transplantation. As you can see, that's the complete remission observed in 9 patients, partial remission in 3, while death in 2 patients. And looking for all the cohorts, we have 9 dead patients. All of them, the majority of them, due to severe lung involvement and also sepsis, intracranial bleeding, and post-transplant, we lose 2 patients. And the overall survival in LRBA deficiency was less than CTLA4, as you see here. And also looking for the transplantation, the LRBA patient, that's the patient with the transplanted or not transplanted. They don't have too much difference in the probability of survival. And also in terms of the diagnostic delay, this not change too much the transplantation outcome. Especially the lung involvement or GI involvement, lymphoproliferation, autoimmunity, they all affect the outcome, and they show less favorable results when compared to patients without those manifestations. And finally, we also look how was the outcome when we compare a patient receiving immunosuppressant or abatacept during this period, and compare this after transplantation period. When you look to the patient who receiving immunosuppressant without those apart from the abatacept, and compare this to transplantation, you can see the transplant patient showed very nice the outcome, while the patient with immunosuppressant died the time. So we did the same analysis with comparing the abatacept to transplantation, and it's very nice that there is no change between there is no differences between 2 treatment modalities, and this shows that abatacept can change the nature of the disease. To conclude here, so what we extracted from our cohort, that's after initiation, when we decide to initiate abatacept or transplant patient, this should be an early stage of the disease, because when we start those treatment late in disease course, this may not be sufficient to induce disease remission or prevent life-threatening immune dysregulation. Also, the prognosis depended, as I said, to early diagnosis and prevention of the end organ damages. And usually, symptomatic patients should be followed with the immunoglobulin replacement therapy and antimicrobial prophylaxis. And we highly recommend it to looking for the regular screening for viral pathogens, especially CMV and EBV, which was quite high in those patients, and especially after diagnose the LRBA mutant patients. And if they developed any symptoms like autoimmune, lymphoproliferative, or GI manifestation, and after excluding the other possibilities like malignancies or infection, abatacept can be considered a first-line targeted drug to achieve better disease control. As we observed that abatacept is well tolerated in those patients without side effects, and usually 10 to 20 milligram per kilogram per month being the most frequent use and able to control the manifestation. But we should keep in the mind that the efficacy of abatacept on symptoms can be changeable and depend on the manifestation, especially the lymphoproliferation and chronic diarrhea respond very well compared to the immune dysregulatory manifestation. Therefore, every patient should be evaluated separately in terms of this kind of therapies. And lastly, when they follow those patients to a long-term outcome, if they have well controlled and well disease controlled, abatacept can be stopped in some patients while keeping them very close monitoring and follow up with immunoglobulin replacement therapy and prophylaxis for the long term. And also transplantation, as we saw in our cohort, should be performed at early stage, especially to patients who don't have access to abatacept, or they have a very severe phenotype, also resistant to immunosuppressants, and they showed severe side effects due to these kind of therapies. So I would like to stop here, and thanks to valuable collaborators from Turkey, they to send and help us to recruit all this data, especially to my students Nigar and Royala for their great job. And also I would express my condolence to our countries, especially for this catastrophic earthquake in South Turkey, which led to death of 1,000 people. So thanks for your attention.
Thank you, Safa. This is indeed a horrible shock which happened, and we are seeing those horrible pictures in the news, and we feel with you, and we can only hope that as many individuals as possible can be rescued, because we know that Turkey has great physicians, and at least from this side, I hope they can deliver help.
Thank you.
Thank you for this very important and great presentation, and also thank you for sharing your unpublished data with us, and that is amazing. And we will come back to the questions. There are many questions now popping up. But before we do so, I will ask Dr. Máté Krausz to talk about the study we have conducted here at the CCI in Freiburg on CTLA4 and LRBA deficiency and abatacept. Máté, the floor is yours.
Thank you, and welcome to this very interesting evening about CTLA4 and LRBA disease. And in the coming minutes, I would like to share our own experience that we have gained during the ABACHAI clinical trial that we conducted, or actually we are still conducting here in Freiburg and in Hanover in Germany. So as it is probably now kind of known to everyone, CTLA4 and LRBA disease share a common trait, that is both of these diseases or mutations in CTLA4 and LRBA lead to an insufficient or functionally deficient CTLA4 molecule that leads to the prolonged activation of T cells that is causing the multi-organ immunopathology in these patients that leads to the multiple autoimmune organ involvements. And therefore, that in both of these diseases, the deficient CTLA4 expression is present. One can have the idea to substitute as a targeted therapy option abatacept, which is a CTLA4 molecule coupled with an immunoglobulin part, as a targeted treatment for both of these diseases. And that's what we try to achieve in terms of the ABBA clinical trial, to assess this therapy systematically in these two patient groups. The primary objective of our trial was to assess firstly the safety of this medication in these patient groups with CTLA4 and LRBA disease. This we have measured by the severity of the side effects with a special focus on infections. And the secondary objective was to assess the efficacy as well of this treatment. And the efficacy we have measured by some single outcome parameters, lab values. As well, we have proposed a new disease score for the CTLA4 and LRBA disease, which is the CHI score. The CHI score was based in our center and developed on the basis of the CTLA4 worldwide cohort, which exists of more than 200 patients. And this allows for two excellent purposes. One is to assess the current disease activity in studies like ours, and where we can follow the score during the trial as of response for a treatment. As well, it is used for, as I will show you later on, in the research settings where one can calculate a score from disease-fair periods, which might be used for retrospective categorization of the patients. The score exists of 7 main categories, and for each category there are multiple diagnostic criteria. For each one can score from 0 to 3 points, and in the end you can throw an average that will give you the CHI score. The higher the score, the more active the disease is. And now how the trial was run. So it was a phase 2A prospective trial, non-randomized, open label. And we have 2 centers in Germany, one in Hanover, one in Freiburg. Altogether, there were 20 patients included in this trial and were treated for a period of 12 months with abatacept. The doses we have chosen is 125 milligrams subcutaneously each week. And we have included 2 kinds of patients. For an observatory arm, we have patients who have been already on the medication for some time, and we have also had treatment-naive patients. And after a screening visit, we have performed multiple on-site visits with lab values and clinical examinations. As well, in between, there were multiple phone visits. And now I would like to share some preliminary results from the center Freiburg, as the center in Hanover is still treating patients. In Freiburg, we have included 13 patients. 12 of them were treatment naive, 1 was pre-treated, and 11 were having CTLA4 mutations, and 2 were LRBA patients. In Hanover, the rest of 7 patients were included, all of them having CTLA4 mutations. 4 of them were pre-treated, and 3 of them were treatment naive. In the beginning, at the screening examinations, based on similar to the CHI score that I just showed you, we screened for organ involvements to see what the categorization of the patients are. And as might be expected, most of them have gut involvement and immune system involvement, mostly immunodeficiency and antibody deficiency. Less common were lung, skin involvement as lymphoproliferation. And we had only a few patients with cytopenias or central nervous system involvement. Now to the preliminary results. So as I told you, the first and the primary endpoint of the trial was to show that this treatment is safe for these patient groups. And firstly, we measured that by the number of infections. And here we had to deal with special conditions, as the trial we have started in the summer of 2020, in the middle of the COVID-19 pandemic. And that had, of course, some influence on how the number of infections turned out during the trial. Luckily, we only had from, at the moment, as far as I know, in the center of Freiburg, at least 3 cases of COVID-19 in the trial. And from these, only 2 patients had to be hospitalized, and luckily not for severe disease, so not for intensive care treatment, but rather that these patients can receive intravenous immunoglobulins as their regular treatment, or in the beginning remdesivir or some other specific therapy for COVID-19. As in the previous talk it was mentioned, we also had suspected that the EBV or CMV reactivations might occur in these patients during the treatment. However, we didn't measure any reactivations during the course of the trial. And we also couldn't see any severe infections in these 13 patients during the trial for which they needed to be hospitalized. And what the treatment outcome was, from the 13 patients, 10 completed the trial with the full 12 months of treatment. And we had 3 premature terminations, all of them due to a severe adverse event. And case reports I will share later during the talk. From the 10 patients that have completed the trial, 9 of them have decided that they profited from this therapy and want to continue with the abatacept treatment continuously after the trial, which shows that there was generally a good tolerance of the medications. And 1 patient that didn't continue directly after the trial, after a short break, she also took on with the medications. And 1 patient had discontinued the abatacept after the initial continuation. And this I will also discuss in a later case report. What regarding therapy response, we measured it, tried to categorize it by organ involvement, as you have seen it also in the previous talk by LRBA. And we have seen that gastrointestinal symptoms, so the gut disease, responds fast and swiftly to the abatacept treatment. And the treatment allowed for the patients in the trial to reduce or completely drop topical corticosteroids and potassium supplementations. For the skin disease, we had 1 patient with severe alopecia, and she showed excellent response. However, 1 patient in the center in Hanover had severe eczema before treatment initiation, and she did not respond for it. For the monitoring the therapy and for T-cell proliferation and activation, we found that the soluble interleukin-2 receptor is a great lab parameter to monitor the therapy response as well as disease scores. As you can see from the baseline, already at 3 months into treatment, we see a fast response, which is not yet significant. But at 6 and 12 months, we see a huge and stable drop of the interleukin-2 receptor during abatacept treatment. For the cases of cytopenia, we had 1 patient who relapsed during the trial, and this relapse was also therapy refractory to abatacept. We had also 1 patient with a kidney disease, with probably in terms of the CTLA4 disease, that was developed actually under the treatment with abatacept. For the central nervous system, we had 2 patients who had history of involvement, and they did not relapse during the trial, so there were no active flares, and our analysis for the lung disease is still pending. And now I would like to share a few interesting case reports with some take-home messages for maybe your patients as well. The first one is the case with the therapy refractory ITP This is a 22-year-old female patient with CTLA4 disease, history of enteropathy, ITP, and skin involvement. And for her ITP, she received rituximab treatment before trial initiation. And after the needed time period was gone, we have started abatacept 6 months later. And during the trial, 4 weeks into the treatment, she had an undefined, undiagnosed gastrointestinal infection, which probably triggered her ITP. As well, she relapsed into progressive gastrointestinal disease as well. And this was not controllable with the abatacept treatment, as well as the maximal allowed prednisolone doses in the trial, which was 20 milligram daily. And after losing 20 kilograms of weight, having persisting diarrhea and an uncontrollable thrombocytopenia with immunoglobulins and thrombopug, which are allowed medications, we have decided to stop the abatacept treatment, stop trial participation, and she received again rituximab for her ITP and showed good response again, and received filgotinib for her gut disease, showing good response initially. From this one can take home that the ITP in case of CTLA4 disease might not be abatacept monotherapy is something that might be sufficient in this case. The second case report is about worsening kidney disease in a 41-year-old male patient with complicated CVID with enteropathy, interstitial lung disease. When we have started the abatacept in the trial, this patient had normal kidney values, especially normal serum creatinine. And as you have seen, he had a really high interleukin receptor in terms of immune activation, which was dropping initially quite good, but stayed stable during the trial. And also this patient subjectively did not show good response to abatacept. However, during the trial, we have seen the serum creatinine values rising. And this was the patient who have stopped abatacept treatment after finishing the trial, partially due to advice from his nephrologist, as they were suspecting that this might be a side effect of the treatment. However, kidney biopsy revealed T-cell infiltrates and almost complete fibrosis. So this patient again started abatacept treatment, but likely there will be another immunosuppressive therapy needed to control this disease. So here again, the take-home message is that the kidney disease is also something that in case you might decide that abatacept monotherapy, or at least in the doses that we used, might not be sufficient. The third and fourth case are combined together, and it's about biliary disease. The first one is a 28-year-old male patient with complicated CVID with severe enteropathy, alopecia, who have presented with a severely low BMI at trial inclusion with pre-existing gallstones, and showed a really fast response to abatacept, gaining more than 20 kilograms of weight over 6 months. And parallelly, he have developed a symptom complex that resembled mostly metabolic syndrome. And also he didn't reduce his corticosteroids. And a few weeks after 6 months into the trial, he had developed a biliary pancreatitis. And after long hospitalization, we lost this patient in sepsis. The second is a similar story with a young 23-year-old LRBA patient with recessive cytopenias and enteropathy. And she also had known gallstones before trial inclusion. It was rather with a low BMI at inclusion and severe gut disease, which gut disease responded very well for the therapy with abatacept, gaining more than 10 kilograms over 3 months. And she started to have biliary colics 4 months into the trial. Luckily, she have underwent an elective cholecystectomy at 5 months, and she's still receiving the treatment as healthy. Here, the message might be that an asymptomatic gall disease can or may progress during treatment with abatacept due to the immune reconstitution. in case of severe gut disease, and the rapid weight gain and possible metabolic changes. And the screening of gallstones might be something that one could think of before initiating abatacept therapy with patients in gut disease. And the last case was another case where we had to stop treatment prematurely in a case of a 52-year-old female patient with CTLA4 disease and Evans syndrome in the past, and enteropathy and interstitial lung disease. And because of the Evans syndrome, she was on long-term treatment with romiplastim. After trial inclusion, she showed a subjectively moderate response, and after 6 months into the treatment, she progressed into leuko and neutropenia, where a bone marrow analysis showed the sign of an acute myeloid leukemia, which to my knowledge is at least one of the first cases in CTLA4 disease with a myeloid leukemia. And here we had to stop the treatment, and she received bone marrow transplantation, which is a very good treatment for the myeloid leukemia, but as you will hear, also for the CTLA4 disease. So as a summary, I introduced you to the ABACHAI clinical trial, and as well the CHI score, that is our novel proposed disease score for the CTLA4 and LRBA disease, showed some preliminary results that show that we had no hospitalizations for severe infections, no EBV or CMV reactivations, as well generally a good response for the gut involvement. And from the case reports, what I think it is worth that you take home that firstly, the gallstone disease may progress into a complicated disease during the immunomodulatory treatment. In case of ITP and kidney disease and skin disease, and monotherapy, at least in the current doses, might not be sufficient. And we would like to warn you, or at least to warn for caution, in the combination therapy with abatacept and romiplastim and the CTLA4 deficiency. The trial protocol is published and you can access it online. And with that, I would like to thank all the trial participants, our trial team, as well as the center in Hanover for their work in the trial.
Thank you, Máté. Thank you for the presentation of these interesting cases. And to not lose time, we will move swiftly to the next presentation of Claudia and Carsten, and leave questions after the last talk. Please go ahead, Carsten and Claudia.
Thank you, Bodo, for the introduction. So Claudia and me will present 2 cases to discuss the therapeutic option of HSCT, in particular for CTLA4 deficiency. So the first case is a pediatric case. He's a male patient and was the first child of non-consanguineous German parents. His history of disease started at 10 months when he developed diarrhea that was then chronic and resulted in failure to thrive. He then developed recurrent respiratory infection that also got worse and resulted in the first inpatient pneumonia at 4 years of age. He then developed generalized lymphadenopathy and profound splenomegaly at 5 years, and at the same time he also experienced intermittent flares of ITP. At that time he was referred to us for immunological workup, and we identified the patient to have low immunoglobulins. He had significantly reduced B cells, moderately reduced NK cells, a very marked reduction of naive T cells, almost no detectable class switch memory cells, and an expansion of CD21 low B cells. Here you see some clinical pictures of the patient with this very profound generalized lymphadenopathy. He had a spleen that was enlarged all the way down to the pelvis, and he had this dense, large lymphocytic infiltrates in the lung that are quite typical for CTLA4, but also LRBA deficiency. And you also see very dense inflammatory infiltrates in the intestine. Genetics identified a nonsense mutation in exon 2 in CTLA4, and we also identified that the father was carrier of the very same mutation. However, the father was only very mildly affected. In the past, he was treated for moderate colitis intermittently with mesalazine. He didn't receive treatment at this time point. However, he also refused to undergo a further detailed immunological and clinical workup. We also identified that the not affected sister was HLA identical to her brother, and given this intense clinical phenotype, we decided together with the family to move on with stem cell transplantation in this child. We tried to achieve stabilization of the clinical condition, and before moving on to transplant, decided for this bridging treatment plan. The patient was put on subcutaneous immunoglobulins and cotrimoxazole prophylaxis to prevent further infections. And we started immune modulatory treatment with abatacept at 50 milligrams subcutaneously once a week in this child weighing around 25 kg. And we also initiated oral prednisolone treatment with 1 milligram per kg that we tapered down to 0.2 over a time period of approximately 8 weeks. We saw very good clinical improvement. The general condition improved markedly, and also the lung disease as shown here, and the intestinal inflammation all improved very well under this regimen. So we then moved on with transplantation 6 months later at the age of 6 years, following a conditioning regimen that can be classified as reduced toxicity regimen containing thiatepa, triosulfan, and fludarabine. He received serotherapy with ATG and GVHD prophylaxis with MTX and CSA. He then received bone marrow as a graft in the indicated dose, and that resulted in very prompt neutrophil engraftment and full donor chimerism from day 25 onward. Overall, the transplant course was really uncomplicated. There was no signs of GVHD also in the later course, and the patient was discharged and seen as an outpatient from day plus 43 onward. At last follow-up, the patient was 8 years, so 2 years after the procedure, in excellent overall condition. He remained full chimerism, had normal hematopoiesis and a normalized immune phenotype. He was off any medication, including subcutaneous immunoglobulin substitution. He remained a mild, palpable splenomegaly, but otherwise no residual disease manifestation. So I hand over to Claudia now, who will present a second case from the adult department.
Yeah, thank you, Carsten. We would like to share with you a case of a 45-year-old male. Carsten? Yes, he has a very typical history of CTLA4 haploinsufficiency. He had atopic dermatitis since childhood, tonsillectomy at the age of 4, diabetes mellitus of type 1 at the age of 6. Then he continued as a teenager with thrombocytopenia and received splenectomy at the age of 16. He started to have lymphadenopathy at around 30 years of age. And then he started to have recurrent pneumonia at the age of 34, at the age of 35 with acute respiratory failure, and again at the age of 36 when he was intubated. He also developed interstitial pneumonia at the age of 35 when he also had a lot of infections. And then he had pneumococcal meningitis at the age of 39. He survived all that and was diagnosed with a heterozygous mutation in CTLA4. And with this knowledge, he was then started on abatacept. In the next slide, we can see that he, unfortunately, at the age of 41, during abatacept treatment, he was diagnosed with classical Hodgkin lymphoma of stage 4. It was not EBV associated. Then he went on to conventional chemotherapy treatment. He had progressive disease to the first-line treatment. He had progressive disease to the second-line treatment, and he was also refractory to brentuximab treatment. So he was a 41-year-old male in good condition, but with refractory lymphoma. And yeah, there were not many options left, so we went on to allogeneic stem cell transplantation at the age of 42 from a matched unrelated donor. He received myeloablative but reduced toxicity conditioning with thiotepa, fludarabine, and melphalan, and a GVHD prophylaxis with rapid ATG, cyclosporine, and mycophenolate. Next slide. He is now 3.5 years after transplant. He is in complete remission for his Hodgkin lymphoma. He does not have GVHD. He has good lymphocyte reconstitution, as you can see here. He does not need IG supplementation, and he does not have infections anymore, but he continues to have mild chronic kidney disease, most likely toxic from his diabetes and the cyclosporine treatment. Well, I would now like to share with you his pedigree. He has 3 children who carry the same mutation, and we are in current discussions on, well, when's the time point to initiate what treatment. And Carsten will now share with you the published experience on CTLA4 and the published experience on stem cell transplantation in CTLA4 haploinsufficiency.
Yes, thank you, Claudia. So how do these 2 cases we just discussed fit into the landscape of published experience? So what has been out there reported? The first report was put together by Mary Sletter in 2015, reporting on 8 patients. The majority of these patients had a retrospective diagnosis of CTLA4 deficiency. Charlotte Schwab reported overall on 12 patients in her larger clinical report on CTLA4, and this report included 6 of the patients previously reported by Mary. And David Eck very recently put together a very nice report on the different management option for CTLA4, overall including 18 patients, which includes the majority of the patients of Mary and Charlotte, and also some cases previously reported in literature as single case reports. So these were overall 18 reported patients in these 3 papers. In the reported literature, there is a predominance for male transplanted patients. If we look into the reasons for transplantation, then you see that in the majority of cases, patients were transplanted for various immune dysregulatory problems. In some cases, infections, but immune dysregulatory problems really have been the main reason to undergo transplantation. There have been 2 patients, 1 adult patient and 1 teenage patient who were transplanted for Hodgkin lymphoma, very similar to the case that Claudia just presented. There's significant delay between age of onset and eventual transplantation, so it can be assumed that the majority of patients have a long clinical history of severe organ involvement before undergoing transplantation. The conditioning regimen are very heterogeneous, of course, also reflecting different center policies, but the majority of patients received a reduced intensity or reduced toxicity scheme. 12 patients out of 18 were transplanted from a 10 out of 10 matched donor. So there is also a significant number of patients receiving mismatched transplants. Graph was half the patient receiving bone marrow, the other half PBSC. The outcome has been 13 alive out of 18 transplanted patients, and among the 5 who deceased, there has been clearly treatment-related mortality in 4 of these patients. So certainly a significant risk in these patients with a long history of critical organ involvement. Also quite relevant and also probably reflecting this inflammatory precondition before transplant is this high rate of GVHD. And there have been also 2 patients who deceased because of grade 3 to 4 GVHD. I'd like to mention that there are further published experiences. One is a cohort paper on 226 transplanted patients with primary immunodeficiency involving various immune dysregulatory inborn errors by Alice Chan, published in 2020. And among these were 13 patients with CTLA4 and 4 patients with LRBA. However, there is no subgroup analysis for these various defects that were included in this work, so I did not include this in the discussion here today. And I also like to point out that there is a dedicated paper reviewing the transplant experience in LRBA put together by Victoria Tesch from the Markus Seidel group, who reported successful outcome in 17 out of 24 transplanted patients with LRBA. So very similar to the single center experience that Safa previously shared with us, and also very similar to the data for the CTLA4 patients. So in conclusion, yes, HSCT can be curative for these conditions. However, the published experience relies on small numbers of reported patients, and many of those had a retrospective diagnosis. There were only very few patients, 1 or 2, who were published, who were previously treated with a soluble CTLA4 fusion protein, which, as we heard, of course, might be beneficial to use as a bridge to transplantation. What are the risks of using these substances for long-term treatment instead of going into transplant compared to the risk of HSCT remains to be studied, ideally in prospective trials. And we must consider, however, both options, of course, and counsel affected patients and their families carefully when offering these treatments. The optimal timing for HSCT has also been discussed, is unclear at the moment, but of course, if we compare this to other conditions with significant inflammation, it is likely that also here earlier transplant is likely to lead to superior outcomes. But again, we must consider the here really variable phenotype even within families who share the same mutation. There might be even affected members who do not need treatment at all, so this really needs careful counseling. So overall, we really need data on the long-term outcome in these patients, and with this, I'd like to point out that there is currently an ongoing outcome study on HSCT for CTLA4 carried out by the Inborn Error Working Party of EBMT. So if you have patients transplanted for CTLA4, please get in touch with us, send an email to Christo, and we would be very happy to share the CRF and to include your patient in the study. So thank you very much for your attention.
Wonderful. Thank you, Carsten. I realize that it's now quite progressed in time. So I wanted to ask Margareta and the ESID coordinators whether it's possible to the question and answer session now and move Máté's talk to the very end. Is that possible?
Certainly, certainly. We can do that, certainly, Bodo.
Thank you. Thank you. So while we get the panel together, I would like to start with the questions put forward to Elena. Elena, you have been asked to answer whether we have also quantitative defects in CTLA4, but normal transanesosis assay. So Thomas Fox asked that. And whether how do we deal with situations where FOXP3 positive regulatory T cells are low, and how we interpret CTLA4 expression in these cases. And then most interestingly, Francesca Conti asks whether the transaneophytosis assay can also be conducted while the patient is on abatacept treatment. Elena.
Thank you. Thanks a lot for the questions. To the first question, we have not had any CTLA4 variants where there's a difference between the transendocytosis and the expression, so usually those correspond. If the transendocytosis is reduced, the expression is also reduced, and the same if it's normal. It would be interesting to analyze other trichopathies, though, in, for example, CD25 deficiency, to see if their CTLA4 is reduced and transendocytosis is normal, but so far we have not analyzed any patients yet. So this would be something to do.
Thank you.
And then,
yeah, go ahead.
To the second question, so what we always do when we analyze the CTLA4 expression is also do a surface staining for memory CD4 T cells. And we also sometimes have low Treg numbers, and then we look at the CTLA4 expression in these memory T cells. Of course, this isn't optimal, but usually it corresponds with the regulatory T cells. So this also gives you a first impression if CTLA4 is reduced.
In the influence of abatacept?
We have tested patients that are also under abatacept treatment. It doesn't have any influence because it gets washed out before we perform the assay. So I also got your email just now, so I will send you the details how we can go further with the analysis of your patient. But it's definitely possible also under abatacept treatment.
Yes, I also think so. Is there any comment from the other panelists regarding the staining and the interpretation? If that is not so, then I can tell. Gulbu?
I can tell one thing about the very low FOXP3 expression. So that's why when you culture these cells in media or low dose IL-2 for 48 hours, it perks up the FOXP3 expression a little bit, so you can define the Tregs a little bit better. So that's why I always like to do the 48-hour low dose IL-2, like 50 units per ml. It helps a lot for very low CD25 and FOXP3 expressing Tregs in these patients.
That's a good suggestion. Thank you. So may we stay with you, Gulbu, and the question was whether you think that sirolimus is good for all complications, or is sirolimus maybe better for the cytopenias and some other types of organ involvement, but it may not help as well in other organ involvements? Do you have an overview of sirolimus working for?
Yeah, that's what I was trying to do. Yeah, I mean, that's what I was trying to actually allude when I brought up you need to know what you want to treat. So it works beautiful for most cytopenias and lymphoreduction, controlling lymphoproliferation. It doesn't always work by itself for neuropathy. It usually is much better when combined with abatacept. I would not just use sirolimus for CNS disease. And then if you're a patient with already existing kidney disease, I wouldn't use sirolimus. The one thing that you need to really pay attention to is to potassium loss. With in some patients, you get progressive potassium loss with sirolimus use. Prolonged sirolimus use. It's hard to predict who is that going to be. You just need to check that. But other than that, it works for many problems as long as the patient is not overly dysregulated. For example, if you get a patient that has had so many complications, there are so many different cytokines, pathways altered, chemokine receptors all over the place. It's just really hard to control his disease just expecting with one single drug. So it is not just only the target tissue, but also the duration of the complication and combination of which other symptoms.
And do you do always IV, or do you also have experience in comparing IV with subcutaneous?
For abatacept? More IV because we can give a much higher dose. That's what when I say high dose, we do it twice the regular dose at least, like IV, and then combine sub-Q in between, because it's really hard to get patients to where we are every 15 days, right? So so what we end up doing is giving an infusion every month, 2 infusions back to back at regular dose, but 2 days back to back once a month.
And do you have the impression that the IV is more efficacious than the subcut, or can you not say? At the same dose.
So to be able to give the same amount of sub-Q, that will be quite, but we already combine sub-Q with IV. So when you have a soluble CD25, that's very high. So then we do in between the IV doses, I do once or twice a week sub-Q. So
Safa, do you have Safa? Thank you, Gulbu. Safa, in your
patients end up getting.
Yeah. Safa, sorry for the time delay. Safa, in your cohort, do you see differences between subcut and IV efficacy? And how do you dose the abatacept? We can't hear you.
Yeah, sorry. So we usually use IV route to treat patients, but for sub-Q, we use this during the pandemic, the COVID pandemic, when they have problem with the admission to hospitals. So we switch from IV to sub-Q, but we don't have any patient started initially with the sub-Q. So I don't know how it's can control the symptoms. I don't have experience for that.
Then I have a couple of questions. One participant asked, do you do antifungal prophylaxis in either one of those two conditions? This is primary antifungal, not secondary. So once the patient has manifested and needs secondary prophylaxis, I agree, that's no question. Yes. But is there an indication for primary antifungal prophylaxis in CTLA4 or LRBA insufficiency?
This is for me, right? So
that's from my standpoint.
So for what we do, it's not like a primary prophylaxis, but there's some patients with the very low CD4 and they don't have nice proliferation. So as we did in the combined immune deficiency, so I prefer to start antifungal. But this is very small part of the patients. But
Gulbu, is it the same at the NIH? And is there a CD4 T cell number which you take as a cutoff?
No, I mean, I don't, because this disease does not normally predispose to fungal infections, right? So, I don't put fungal people on fungal prophylaxis. Although there are several patients that live in the high cocci endemic areas that they had invasive cocci infection, but that's only in Arizona and Southern California. So that's the only thing. But normally, no.
Okay, I agree. So in Freiburg, we also don't use antifungal prophylaxis unless the patient has manifested with the fungal disease, and then sometimes we carry on. Another question to Safa is: you talked about quality of life in your patients. What were the measures you took for measuring quality of life? Is it a questionnaire, or how do you assess quality of life?
Yes, it's questionnaires. The Kindle. We use Kindle.
Which one?
Kindle.
Kindle.
Yes, the German.
No, I've never used it, so I'm very happy to learn about it.
Yes. So it is international quality of life, and also.
Is it focused on immunodeficiency problems?
No, it is general. Yes.
Okay, cool. Thank you. Then in your report, did I understand correctly that the LRBAs did respond more favorably to the abatacept than the CTLA4s? Safa?
Yeah, no. I mean, so this is I showed the data from that part. Usually, in the partial response cohort, there is the majority of them LRBA patients. Only one CTLA4 partially responded for the yes. So the majority LRBA.
And then I had the question whether you also looked at this soluble IL-2 receptor, which is a soluble CD25, as a marker for disease. And can you confirm what Máté has introduced, that this might be a good marker for disease activity?
Yes, I think we checked for the first cohort the soluble CD25, and it was high in the patient, and it also decreased with the therapy. So yeah, I think it's quite similar to TFH, and it's a reliable marker.
Is that your experience as well, Gulbu?
No, I mean, yes, I like it. I like following, but it is not elevated in every sick patient with CTLA4. So when it is there, when it's elevated, you can follow over time. It's helpful, but not every patient will have elevated CD25, which is very interesting, right? I mean, why due to so they're less of a Treg deficient problem, more of an effector T cell or dendritic cell problem? That's something that I guess needs to be figured out, but it's not always there.
Yeah. Then Safa, there are specific questions for support in patients with LRBA deficiency. So maybe you can go on later into the chat, the question answer session, and answer those specific questions. But in general, do you think those LRBA patients are more difficult to transplant than the CTLA4 patients because they are possibly more sick, because they have possibly acquired more complications in more organs? Is that a timing question? And if you catch those, or if you transplant them early enough, the LRBAs, maybe it's also a better favorable outcome? Is that kind of the message, that we should transplant the LRBAs earlier?
I think this is it's hard to answer, but I think it's early diagnosis is the better way to see how we can manage those patients, because if you have many organ involvements, the transplantation will not doing very well in those patients. That's why early I prefer to let's say that early diagnosis, and then starting if there's symptoms abatacept, and then consider transplantation if there's a good donors, also if there's a good facilities for transplantation, and then maybe that's option. But at early stage, I do not prefer, like if I have abatacept, I prefer to use it first and look.
Carsten, do you think that the disease itself makes LRBA more difficult to transplant than CTLA4? Or is it in principle the same if you catch them early enough without these organ complications?
Well, I think for a final statement, I mean, that's too early. I mean, it's so little patient numbers. In principle, I would think yes, but I think for all the different treatment options, we really need long-term and clear data. And what I find tricky here is really that for both diseases, even within families, the phenotype can be so different. And I mean, that's different to other diseases where you have very clear genotype-phenotype correlation, where you can say once you start to have symptoms, you're likely to have develop more and more and an aggressive course. I think the concept suggested by Safa that, I mean, to make the diagnosis and follow patients carefully, and yes, consider the option of a transplant early, do a donor evaluation and be ready to step in and to counsel the families. And I think that's a very individual decision that needs to be discussed with each family. I think it's much more tricky to counsel these families than in other immunodeficiencies because of the variable phenotype.
Claudia, I have a question for you. How often would you advise us to look for EBV viremia and for EBV associated complications in those CTLA4 patients? Is it yearly, half yearly, even more frequently? Do we need to do EBV count in blood? What would be your advice? Is it okay to just palpate lymph nodes? Do we need an abdominal ultrasound for intra-abdominal lymph nodes? What would you advise?
I'm very biased because I tend to see those who have EBV-associated lymphoma or EBV-associated lymphoproliferation because I'm a hematologist. So perhaps I would go for the EBV viremia every 3 months and a clinical investigation of the lymph nodes every 3 months. But this is not evidence-based at all.
Gulbu, Safa, do you agree with the frequency, or do you think less frequent is also okay?
I mean, if somebody is on IV abatacept with CTLA4 defect, who has had EBV viremia before, absolutely. I mean, every time I see the patient, we check EBV and CMV, but also have been, for the last couple of years, we've been checking for BK and JC viremia as well, because a couple of patients had problems with that. Yes, if you think about it, you should do PCR.
Great. That's a very important statement. We do not do that in Freiburg yet, but I think that's a very important statement. And thank you for that. Well, now we come to the probably holy grail question, when to stop abatacept. I know from some patients who are now asymptomatic that they had bouts of gut disease previously, and for some unknown reason, the immune system got deactivated by itself. And now they are kind of asymptomatic, but there were some times when they were not. Is there a possibility that abatacept takes down the immune activated system and we can stop it and then see what happens? What do people think?
I mean, I think that once you get over the excessive immune dysregulation, and if you have fully control of the symptoms and being off abatacept, and then yes, you can stop. It doesn't mean that a patient who has been really sick, very well controlled, weaned off, will flare again. You just need to have to get over that extreme immune dysregulation, cytokine imbalance, and dysfunctional Treg phase. A lot of people have done well, or at least have reduced to minimal sub-Q abatacept dose of every other week single dose, which is, I think, very sustainable as compared to a lot of IVs and oral drugs, etc.
Thank you, Safa. There's a question for you from Emma regarding LRBA patients. Do you observe often HPV-associated warts, perianal disease? Her patient is on sirolimus.
No, I didn't see any HPV, even the sirolimus patients. I never see.
So LRBA patients do not have, they might have an increased risk of viral infections and viral.
They have might, but it's not. We saw herpes simplex and varicella zoster infection in some cases, EBV also, but
in papilloma viruses. She's asking about papilloma.
No, I never see papilloma.
Oh, that's great. Bushra asks, I didn't notice severe cutaneous associated autoimmunity in the reported manifestations, psoriasis or vasculitis. Is it related to the steroid burden of these patients? We do see eczema. So eczema and psoriatic-like lesions are frequently seen in these patients. Vasculitis is more a sign of NF-kappa B disease. Do people agree?
Yes.
Or ADA2, ADA2, of course, big problem causing vasculitis. Great. Alice Chan asks, are the patients who are refractory to abatacept developing anti-abatacept antibodies? And if so, is it being tested in the clinical trial? I do not know of any company or any lab offering those anti-CTLA4 or anti-abatacept antibodies. Does somebody know of the panelists whether this is available at all, whether you do it?
Yeah, there's a company that BMS has worked with that they checked. And they did look at this in other rheumatoid arthritis patients or psoriatic arthritis patients. Even if you detect other antibody to abatacept, it doesn't mean it is inhibitory. So you have to do two things. You have to look at the antibody and then take these patients, those antibodies, isolate them and see if they have suppressive effect or inhibitory effect. And they had no.
Would you mind circulating the link? Gulbu, would you mind circulating the link?
I'll find that the lab, and I have to dig in my emails. I'll send it.
Wonderful. That would be very much appreciated. And then finally, Michael Jordan asked, what about the CMV disease in natural history? We are all surprised, actually, that under abatacept, 20 CTLA4 patients, or almost 20 CTLA4 and LRBA patients in 1 year of the ABATA-CHI trial did not manifest with elevated CMV or EBV, which was the initial fear, that if you treat those patients with abatacept, that then the viruses become happy and come out of the blood and multiply in blood. But no, we have not seen that. Is that something you see as a problem, the CMV, in the LRBA patients you follow and the CTLA4 patients you follow, Safa?
No, there is not. It's only like not like the combined immunodeficiency or SCID. So it's when we check from the PCR, some of the patients showed a low level of the CMV, the copy number, but we are following this regularly, and there is no. It's still stable, and in some patients it's going to be negative, but it's not like it's not did so much problem like a SCID or combined immunodeficiency patients.
Guys, we are sitting here for 2 hours now discussing those two very enigmatic and very exciting diseases. Thank you so much for the great discussions. We have still 1 presentation to go. So if you have time, please stay on and listen to Máté's final talk on possible confounder effects, why some patients may stay healthy and belong to the 30% of non-penetrant individuals, and the others become sick, belonging to the unfortunate 70% who carry the mutations and become sick. Thank you. Thank you so much to all the panelists. This was a wonderful discussion. I love the clinical grand rounds Siobhan Burns has initiated. It's a wonderful instrument for teaching. So Siobhan, thank you for that. Thank you for giving us the chance to communicate all what we know about those two diseases. I'm sure there's new things to be published. Safa, we are looking forward to your publication. Thank you for sharing the unpublished results. Gulbu, thank you for dialing in from the other side of the continent, from the world, not from the other side of the Atlantic, I wanted to say. Safa, we wish you and your country all the best in managing this huge humanitarian crisis with the earthquake. If you know something we can help, I know that drugs and medicines are on the way. I think it's difficult to organize things from hospital to hospital, but I know that we can donate money, and we will do so. And we wish you all the best in managing, you and your colleagues, in managing those terrible aftermath. Thank you for all the participants. I learned that we are almost 400 participants today, so 397 people registered, plus us as a panelists makes it 400. So thank you for organizing ESID. Thank you for that wonderful organization. On our side, it worked perfectly. I hope everybody enjoyed the talks. And now, Máté, the floor is all yours for a final presentation on possible modifiers of CTLA4 disease.
Thank you. After a long discussion with treatment, I would like to dive shortly into how the disease might manifest, and
it may only take 6 minutes. I heard
it's fast. So one important aspect of the CTLA4 disease is the gut diseases we have discussed. So therefore, we have asked the questions. The penetrance that we have observed across large cohort studies, that is around 70%, and that is not relevant of the underlying CTLA4 mutation, whether the gut disease might be a disease modifier that decides whether patients get sick or stay healthy with the CTLA4 mutations. And to this end, we have asked 2 questions. Firstly, we wanted to compare the composition of the gut microbiome between CTLA4 mutation carriers and healthy controls, as well to compare this composition within CTLA4 mutation carriers based on disease severity. And to this end, we have collected stool samples from patients, performed the DNA extraction and subsequent 16S sequencing. as well collected the data sets from the clinic, as well the chi-score that I introduced to you in the previous talk of mine, as well a lifestyle questionnaire with, for example, use of antibiotics in the previous weeks, and combine that into our database and perform the analysis. So in this case, what we have used from the chi-score that I introduced to you is a current assessment of the disease, as what we have done is calculated a chi-score that is corresponding exactly or more or less to the sampling of the stool samples, so we can assess how the composition at one time point corresponds to disease severity. And what we have done firstly is to look at the alpha diversity. This is a very common measurement in gut microbiome studies. And interestingly, what we found that patients who are affected by the CTLA4 disease had a significantly decreased alpha diversity compared to healthy individuals, but as well, the diversity was decreased compared to individuals who are unaffected by the disease and have the mutations. And interestingly, there was no difference in alpha diversity between healthy controls as well as the unaffected individuals. So to dive into more details, we have looked at the disease severity measured by the chi-score and the correlation with the alpha diversity. And firstly, what you can find that patients with unaffected clinical phenotype with mild or severe phenotype cluster nicely together. And we can see a nice correlation, negative correlation with higher chi-score and lower alpha diversity. So that means that the more severe the disease measured by the chi-score is, the lower the alpha diversity was in this patient. To go on further, we have performed a phylum analysis looking at the relative abundance of the main phyla found in the gut microbiome. And what we can find in this cohort that the phylum Proteobacteria was nicely expanded in patients with CTLA4 mutations who are affected by disease, but this was not measurable, at least the difference was not significant in unaffected individuals compared to healthy controls. To look more into details, we have again focused on the mutation carrier cohort and performed the LFC analysis and differential abundance analysis, and we could identify some species that are characteristic of the affected or the unaffected individuals. Some of those are actually part of the phylum Proteobacteria that was shown a significant difference between the affected one and the healthy controls. And these species included Bellonella species, Haemophilus species, and Escherichia species that are expanded in the affected cohort. And Lachnospiraceae, Diaster, or Ruminococcaceae were missing in the affected cohort and were more expanded in the unaffected ones. And this was just to gain an overlook whether patients are sick or not. But as we have discussed longly, whether we are sick or not is quite categorical, but these patients can have multiple organ manifestations. And we were interested in also that how the composition of the gut microbiome compares to the manifestation. And what we could find that patients who had lung disease or lymphoproliferation had a decreased alpha diversity compared to skin involvement, and very interestingly, gut involvement. Patients with or without gut involvement or skin disease didn't have a difference in the gut microbiome alpha diversity measured by the Shannon index. However, in our collaboration with the NIH and Liana Falconer, even though there was no difference between alpha diversity, we could identify some species that were expanded or significantly decreased in patients with or without enteropathy. Some of these species are also similar to the ones that we could find in the affected, unaffected cohort. And very importantly, many of these have been already published to be associated with IBD. And then to draw a short summary, I hope I showed you that affected CTLA4 mutation carriers had significantly decreased alpha diversity compared to unaffected controls, as well unaffected CTLA4 mutation carriers. and that the alpha diversity not only correlates with having a mutation, but as well to the disease severity as it is measured by the chi-score. CTLA4 mutation carriers presenting with a symptom that is complicated, related to a complicated disease, had distinct intestinal microbiome signatures, and we could identify multiple significantly different bacterial taxa between affected and unaffected carriers, as well as patients with or without enteropathy. And with all that, we suggest that the change in the gut microbiota might be a disease modifier for the CTLA4 disease. And with that, I would like to thank all my colleagues for their help in the work, especially Bodo Grimbacher and Michele Proietti and Liana Falconer from the NIH, and Hugh for staying so long in this talk in the end.
Thank you very much, Máté. This concludes the webinar on CTLA4 and LRBA insufficiency. And if the panelists have more time, please stay on. I know the recording may end now.